You all know that myeloma is a clonal plasma cell proliferation in the marrow, and it's characterized by features such as hypercalcemia, renal failure, anemia, and bone lesions. And it's caused by genetic alterations. We can effectively treat multiple myeloma with several types of drugs, with alkylators, with steroids, with immunomodulatory drugs, with proteasome inhibitors, and we have also naked antibodies, such as CD38 targeting antibodies and SLAMF7 targeting antibodies like Elranatamab. And with all these compounds, we have significantly improved the survival of myeloma patients. However, when patients become resistant to immunomodulatory drugs and proteasome inhibitors and CD38 antibodies, at that moment, we call these patients triple class refractory, or the disease is triple class refractory. At that moment, the outcome of the myeloma patients is quite bad, with a survival of approximately 5 to 12 months. At this moment, we have several options of treating those triple class refractory patients. Preferentially, I like to enroll these patients in a clinical trial because several clinical trials offer a lot of promise. But outside of clinical trials, because unfortunately not all patients fulfill the in- and exclusion criteria for a trial, outside of a clinical trial, we can use drugs that were used in prior lines in new combinations, or we can use recently approved drugs with novel modes of action, such as selinexor, which in combination with dexamethasone induces a 26% overall response rate in triple class refractory patients. We can use belantamab mafodotin, an antibody drug conjugate, also 30% response in this patient category, with a median PFS of also 3 months. And a similar response rate and median progression-free survival can be seen with melflufen plus dexamethasone in this patient category. So new drugs induce a 30% response rate and a median PFS of around 30%. So we need to do better than this. And I think we can do better at this moment when we look at the data presented at last ESCO and at last EHA, because we have now several new, very promising T-cell redirecting immunotherapies. We know much more about the immune system in multiple myeloma, which contributes to progression and contributes to infections, but we are now able to improve T-cell function, redirect the T-cells to the tumor, and use these T-cells to induce deep and durable responses. So here I want to discuss the new T-cell based immunotherapies, CAR T-cells and bispecific antibodies, and these entities, these drugs use T-cells to combat the myeloma cells. So here you see a picture in which on the left side you see a T-cell, a CAR T-cell. This is a manipulated T-cell, a T-cell manipulated in the lab, because in the lab we have now introduced, by using a virus, a new receptor here on the right. This receptor is called a chimeric antigen receptor, which has different components, signaling components inside the T-cell, inside the immune cell, and an antigen binding part outside of the T-cell. And with this part, the T-cell, the modified T-cell, the CAR T-cell can bind to the tumor cell. And because of this avid binding, this very good binding, the T-cells go to the tumor cell and kill the tumor cell subsequently. The most important target at this moment for CAR T-cells is BCMA, here depicted in red. There are other targets that are in development, but BCMA is the most widely used target. It's a very good target for T-cell redirection therapies because BCMA is highly expressed on those myeloma cells, and apart from myeloma cells, BCMA is only expressed on normal plasma cells and on very mature B lymphocytes. So it's a very specific antigen, which is important because if it's widely expressed, it may lead to undesired side effects. So at ESCO and EHA, there was an update from the KarMMa study. And in the KarMMa study, Tcell is being evaluated. Tcell is a BCMA specific CAR T-cell, which is recently approved in the United States and is now also known as Abecma, that's the new name. And this approval in the US and hopefully soon also in Europe is based on results from the KarMMa study, in which heavily pretreated patients received the CAR T cells after leukapheresis, where you harvest the immune cells from the patient. They are brought to the lab and then they are transformed into CAR T cells. And in that period that the T cells are being transformed into CAR T cells, patients get some type of bridging therapy to keep the disease under control. And at this update at ESCO and EHA, you can see that all the patients that were treated had a very good response rate of 73%, and also a complete remission percentage of approximately 35%. And that's very good if you remember that the currently approved agents in triple class refractory myeloma only induce a 30% response rate. So here we go to 73%. And the complete remission percentage was even a bit higher in patients with only 3 prior lines as compared to patients with at least 4 prior lines. The most common side effects of CAR T-cell therapy in this study were cytokine release syndrome, and some patients experienced neurotoxicity, which was occurring mostly at the time of the cytokine release syndrome and was generally of short duration. So this type of toxicities are produced by the activation of the T cells in the human body, and these T cells cause a lot of inflammatory mediators, and that may result in fever and low blood pressure, and that's called cytokine release syndrome. But typically that can be well managed with sometimes steroids and sometimes a anti-IL-6 antibody. Importantly, with longer follow-up now at this meeting, that we know more about the progression-free survival, which is approximately 8.6 months in all patients, and overall survival in these patients is approaching 24 months. So remissions are durable in heavily pretreated patients. So a very interesting new compound of which we will learn more in the nearby future in studies in which this agent will also be given to earlier lines of therapy, patients in earlier lines of therapy. The other CAR T-cell product that is hopefully soon approved in US and in Europe is called Silpadacel. It's also targeting BCMA, and it was also evaluated in heavily pretreated patients, so mostly patients with triple-class refractory myeloma. Here you see the response rate. 97% of the patients responded with a complete remission percentage of 80%, which is, I think, never seen before in such a heavily pretreated patient category. And remember, this is one infusion and nothing is given hereafter. Response is fast. Best response takes 2.6 months. And we know now also more about the duration of the response, because we know now that the median progression-free survival is approximately 23 months. And I expect that with longer follow-up, this median progression-free survival will even further improve, because there are many patients that are still in remission and censored at the time of the analysis. Because of these excellent response rates and because of the excellent durability of response, also Silpadacel is evaluated in earlier lines of the disease, not only in patients with 5 or 6 prior lines of therapy, like in CARTITUDE-1, but we now also have data from CARTITUDE-2, Arm A, in which patients with 1 to 3 prior lines of therapy and being refractory to lenalidomide were offered Silpadacel. So this is a slightly less pretreated population. And again, we see a very high response rate in this patient category, 95%, CR rate of 75%, and the safety profile was consisting of cytokine release, so patients develop fever and may need some intervention, and there were some patients with ICANS, that is early neurotoxicity, where patients may become a little bit confused because of the high fever, but this typically reacts well to intervention. Other neurotoxicities were rare and only seen in one patient, and this was a grade 1 or 2 event. Importantly, we saw a couple of late neurotoxic events in CARTITUDE-1, but now with a new program of extra attention on these delayed neurotoxicities were not seen anymore. And I think the most important step is that bridging therapy is now much more effective because you give it in an earlier line of therapy and you can use drugs where the patient is still responsive to. Then I want to shift from CAR T cells to another type of T cell redirection therapy, and that's the bispecific antibodies. Bispecific antibodies here on the right are also bringing T cells to the tumor cell. But here, the redirection of the T cell is mediated by an antibody that has two different parts, a blue part that binds to the T cell, to CD3, and a yellow part that binds to the tumor cell, for example, to BCMA or GPRC5D or FcRH5. We have now different bispecific antibodies in the clinical studies that target those antigens. So here, the bispecific antibody forms a sort of bridge between the T cell and the tumor cell, while CAR T cells have a new antenna that results in redirection of the T cell to the tumor. A big advantage of CAR T cells is that it is a single infusion. A disadvantage of bispecifics is that they need to be given continuously, so the patient has to come to the clinic every now and then. A disadvantage of CAR T cells is that they need 6 weeks or sometimes longer of manufacturing, and sometimes that can be very long for a patient that needs treatment because of a rapidly progressive myeloma. And the big advantage of bispecifics is that they are directly available. They are directly available off the shelf. That's what it is called. So at EHA and at ESCO, there was an update on the BCMA specific bispecific antibody Elranatamab, which is evaluated in the MagnetisM-1 study. So here you see that Elranatamab brings the T cell to the myeloma cell. And in this study, patients could be enrolled when they were heavily pretreated. And in this study, we have 87% triple-class refractory patients. And at the ESCO and EHA meetings, we now have an update on the patients that received subcutaneous bispecific treatment. So the first part of this study was with intravenous administration, but this update reports on subcutaneous administration. And we have now defined the optimal dose, the recommended phase 2 dose of Elranatamab, which is 1000 microgram per kilogram. And at that dose, 80% of the patients respond. And also patients with prior BCMA therapy had durable and good responses. Based on these promising results, Elranatamab is further developed as a monotherapy and also in combination with other agents, also in earlier lines of disease. Maybe important to add to this is that the most important side effects are again cytokine release syndrome, CRS. Because of T cell activation, patients may develop fever, but also here we can manage this with some specific interventions. And then we had an update on Teclistamab at EHA and at ESCO. I presented the EHA update and Dr. Krishnan presented the ESCO update. And in the Majestic-1 study, in the beginning, Teclistamab was given intravenously, and later on, because it's more friendly for the patient, it was given subcutaneously. So in total, 157 patients have now been treated with Teclistamab, 73 received subcutaneously Teclistamab, and 84 received IV Teclistamab, intravenous Teclistamab. Also here we have identified the best dose to move forward, the recommended phase 2 dose, and that's 1500 microgram per kilogram administered subcutaneously in 1 minute. And after the first period where you need to be more cautious, the patient can come in the hospital and leave directly thereafter because the administration is very simple. Patients receive 2 step-up doses, first dose is lower and the second dose is a bit higher, and then you go to the final dose, and that is to prevent cytokine release syndrome or severe cytokine release syndrome. And indeed, with this step-up dosing, we saw no severe cytokine release syndrome in these patients. And cytokine release syndrome is the most common adverse event with this agent and also with the other bispecific antibodies. Here you see the response rate, and on the left you see the response at the recommended phase 2 dose. We treated 40 patients at the recommended phase 2 dose, and we have at this dose an overall response rate of 65%, and many of these patients developed a complete remission, approximately 40%, and almost 60% of the patients developed a VGPR, a very good partial response, or better. Also important is that the responses in this study are durable and deepening over time, with 85% of the responders not progressing after a median follow-up of 7 months. And based on these data, also Teclistamab is further developed as a monotherapy in triple-class refractory patients, heavily pretreated patients, but also in combination with other agents, for example, in earlier lines of therapy. And there are also studies starting in newly diagnosed patients to improve the outcome of the newly diagnosed patient. Not only we have now bispecific antibodies targeting the myeloma antigen BCMA, but we also have an agent called talquetamab targeting another protein on the myeloma cell surface, in this case, GPRC5D. So talquetamab targets GPRC5D present on the myeloma cell and redirects the T cells to the tumor cell, brings the T cells to the tumor cell, and the tumor cells are again killed very efficiently, as I shall show you in the next slide. Also here we have defined the best dose to move forward. It's 405 microgram per kilogram, again given subcutaneously, favorable for the patients because it's much faster and much more friendly than intravenous infusion. And also here we have 2 step-up doses to mitigate cytokine release syndrome. Many patients have been treated in a total of 184, mostly with IV, 102, and 82 with subcutaneous Teclistamab. Again, the most common adverse event was cytokine release syndrome, mostly low-grade and easily manageable. Some patients also developed skin reactions and some loss of taste, but this was mostly gone after the first 2 or 3 cycles of the drug. Here you see the response with talquetamab. On the right, you can see the response in the 30 patients treated at the recommended phase 2 dose. We have a 70% response rate with many patients achieving deep responses, including 60% of the patients achieving a VGPR or better. And also here, responses are very durable, with 81% of responders still on treatment, so in remission after a median follow-up of 6 months. So talquetamab is in further development as a monotherapy and hopefully will be approved based on an expansion cohort in triple-class refractory patients. And it's also evaluated in new studies with other agents and also in earlier phases of the disease. And then finally, the last bispecific antibody that I would like to discuss is Sevostomab. This is targeting a third different myeloma protein, in this case FcRH5, specifically expressed on the myeloma cell, and apart from that on B cells, but not on critical tissues other than B cells and plasma cells. At EHA, there was an update of the Sevostomab study in which you can see that prior therapy did not influence the effect of Sevostomab. The response rate was similar across the board. And also differences in prior therapy did not affect expression of FcRH5. Importantly, treatment with bispecifics, in this case a bispecific called REGN5458, leads to deep responses. And that's very important for the patient because deep responses and a manageable toxicity profile improves, as you can see here, the quality of life of the patients without significant deterioration in patient-reported outcomes. So this points to the good balance between efficacy and adverse events of this type of agents. And the same can be said actually from CAR T cells. And that brings me to my last slide, my conclusion slide about T-cell based immunotherapy. I think the updates presented at both ASH, ASCO, and EHA show that CAR T-cell therapy and bispecifics are very promising because they are very effective and show promising toxicity profile. And because of that, they are moving to earlier lines of therapy, sometimes with other agents, and also often integrated into a whole treatment strategy. And hopefully, the next few years, we will learn more from these new studies in earlier lines of therapy. Thank you for your attention.